Hello everybody, and welcome to our symposium here with a nice title, Nuclear Medicine for Alzheimer's Disease in the Hot Seat, a case conference on advancing early diagnosis with PET imaging and biomarkers. So we have a nice group of panelists today, and this is Dr. Drzezga Collij from Amsterdam. It is Professor Silvia Mobelli from Torino, and myself from University of Cologne. We thank to the peer review group for providing this session, and also to Lily for providing an educational grant to organize this symposium today. There will be pollings throughout the presentation, so we want you to participate, which is possible with your smartphone. I'll show this in a minute. You can submit questions also online, and we will try to answer them in the end of the session in a question and answer session. I want also to point out that you can view the slides online afterwards, and also check for more information from peer review and a nice forum to get informed. So our goals for today is update the understanding of appropriate use of PET imaging, provide guidance on the interpretation and reporting, and also how to utilize quantitative analysis, particularly of amyloid PET in this new area of disease-modifying therapies. I will start here with the first presentation of the foundations of biomarker-based diagnosis in Alzheimer's disease. So the main topics here is that we have amyloid targeting therapies now available for treatment of early Alzheimer's disease, and they require biomarker-based confirmation prior to therapy. And of course, we as nuclear medicine physicians need to be ready to meet the increasing demand for PET imaging in patients with risk for AD. And we want to transport here today that amyloid imaging is the gold standard for that, and it may be used to evaluate treatment response and also monitor amyloid clearance. So I listed here the three drugs actually that have been approved in the past, which has been aducanumab, no longer used, and lecanemab and donanemab. Both of them are now also approved in Europe for application. So why do we need biomarkers here? And I think there are four important reasons why we need biomarkers with regard to therapy. One is verification of the disease pathology, so do we have the target in the brain? Second is early detection or staging of the pathology, at which level do we want to treat, can we stratify patients? Three is to measure the outcome of the therapy, is it effective? And four would also be to monitor disease modification after the therapy, and we can discuss this also later. So which biomarker classes do we have available? We have imaging biomarkers, we have fluid biomarkers, which is CSF, and also blood recently, and I will try to a little bit sort their values. So for imaging, we have basically three types of biomarkers available. One for the A category, the amyloid PET imaging, allowing us to assess amyloid directly in the brain. We have tau biomarkers also available that we can measure aggregated tau in the brain. And also we have the good old FDG PET available that allows us to stage the N category, so the neuronal injury. So we can basically cover the entire classification scheme, ATN, as it has been called in the past. And amyloid PET has been a key tool for approval of all the now approved anti-amyloid therapies, starting with the aducanumab in the past, then with lecanemab, which you see on the right side of this slide. And you can see nicely on top of this slide on the right side, the decrease of amyloid in the brain induced by the therapy, which is really very significant here in centiloids, going down more than 50, so it's clearing the amyloid out of the brain measurably, and that is associated with less decline over time, so the patients do not get better by therapy, but they are impairing slower as compared to the placebo group, and that's the case for all of the approved drugs currently. The third drug I would like to introduce here is the donanemab. For the approval of this drug, PET has been used excessively, so amyloid PET has been used for including patients. Tau PET has been used for including patients and sorting them in low and high and intermediate tau levels in the brain. And also these tools have been used for therapy control, demonstrating again, as you can see on the left side here in the bottom, clearing the brain from amyloid, going down even 80 centiloids here, and also with the clinical response that we see on the right side of this slide. But also these tools have been used to measure therapy response and even change the therapy. So if patients were negative, they were switched to placebo, and we will talk about this later. So on the fluid biomarkers, we also can basically cover the classical A, T, and N categories. So we can measure in the CSF the decline of A-beta 42, so the amyloid protein in the CSF is decreasing, reflecting pathology in the brain. We have a p-tau as a measure of Alzheimer's tau in the fluids, and we can measure total tau as a measure of neurodegeneration and also the so-called neurofilament light chains. So these are, again, reflecting basically the same categories, A, T, and N. And we can also do this in the plasma with the important message that it is an orders of magnitude lower what we see in the plasma, because the changes in the brain need to be transported basically into the blood, across the blood-brain barrier, and that we need very sensitive tools to be able to assess these very small differences in the fluids. So how do these markers compare to each other? And there have been recently revised biomarker criteria that actually try to put this into context. They are moving away from the ATN now to so-called core biomarkers. And what is now called Core 1 is a category that basically is mixing different biomarkers. So what we see here in Core 1 is CSF measures of A-beta. It is amyloid PET. It is a T marker, the so-called T1 now, which is the blood p-tau marker on the CSF p-tau marker. And it's also combinations. So for some tests, you would have to combine CSF tau and amyloid values to get to a diagnostic results. So in a way, they are bundling different biomarkers, amyloid and tau biomarkers here, into one category. And they are also bundling fluid and imaging biomarkers into one category. And there's core 2 biomarkers. That is then basically the tau PET, which is suggested to measure stages later in the disease. Also, again, some fluid biomarkers. And the third category is the biomarkers of non-specific processes, such as here FDG PET and MRI. So these three classes have now replaced in that diagnostic criteria the conventional AT and N scheme. So there have been a lot of controversies about these new biomarker criteria, particularly with regard to therapy. And I'm listing just a few here. One is they suggest that core biomarkers are sufficient for a diagnosis of Alzheimer's disease. And that is certainly something from the semantics which is not as easy, because we know many people without any symptoms would be amyloid positive, even decades before they develop symptoms. And it's a bit debatable if all of them should be called patients or if this is rather maybe a risk factor. Also, it is suggested that these biomarkers are interchangeable. So the soluble and the fluid biomarkers are mixed. Some tau and some amyloid are mixed. And there's some asynchrony, which I will also discuss later. Also, we learned that there is no specificity of some of these core categories for pathology, as we have T1 in core 1 and T2 in core 2. Also, the quantification options of imaging are disregarded in this scheme. And there's also different levels of validation, of course, for, let's say, imaging and the blood biomarkers. And the co-pathology problems are unresolved. So according to this criteria, a patient with Lewy body dementia being positive for amyloid in the brain would be called an Alzheimer's disease patient. And I'm not sure this is really reflecting what we do in clinical every day. So there's a lot of positive about this criteria, because they are trying to reflect that there's a stage dependency of the different biomarkers, but there are also downsides with regard to specificity and, let's say, a little bit neglecting the complementary strengths of these biomarkers. So how does this affect therapy? It starts with a temporal asynchrony. And what we see here on this graph is actually how it has been postulated in the past, that there's an order of appearance of the different biomarkers, with the fluid biomarkers being first for amyloid, followed by amyloid PET, followed by the p-tau markers, and then followed by tau PET. And as you see here, suddenly we are bundling these temporal apart markers into one category. And this has effects, of course, with regard to inclusion into therapy, and we see this on the right side of this slide here. It's a nice work where they discussed patients who would be CSF positive and PET negative. This is the yellow group here, labeled here. And patients who would be CSF positive and PET positive. And you can see that those are not similar. So patients who are positive in CSF but still have a negative PET would not show a progress in their disease in a major way, whereas these patients who are positive in CSF and PET would show a steep decline. Meaning, if you would just include patients with a positive CSF, you potentially have these two groups in that population, so patients declining faster and patients declining slower, which is, of course, an issue also with regard to therapy follow-up, indicating that these two biomarkers are not the same, and this is certainly important to know. What about the plasma biomarkers? As mentioned, they are very much discussed now because they are easy to assess, probably also cheap in the future. But we need to be aware that they are not specific for a certain pathology. So the very much discussed p-tau 270 does not reflect tau aggregation in the brain purely, but it reflects amyloid pathology in early stages, and in later stages a mix of tau and amyloid pathology. So it is a good biomarker for Alzheimer's disease, but it is not a pure biomarker for tau or for amyloid pathology, so that's important to know. Also, as I mentioned, the very small changes that we see in plasma are sensitive also to cofactors or to disturbance factors reducing their sensitivity or leading to false positive results. And we see on the right side of this slide here that patients with chronic kidney disease, just as an example, would have the exact same levels of abnormality in p-tau as patients with amyloid in their brain. So there might be false positives induced by cofactors such as kidney dysfunction. And we need to be aware of this because we would certainly not want to treat a patient with an anti-amyloid drug who only suffers from a kidney problem. So that needs to be known. Nevertheless, particularly the plasma biomarkers will be helpful in the future as they are easily accessible. One more point again about the intermediate cases, and that has been shown now for the CSF biomarkers quite nicely, that we end up in sort of a gray zone in patients examined in a proportion of approximately 15 to 20% of patients who would have a value in between a clearly positive and a clearly negative case. And this is real-world data here from multi-center setup studying patients in a dementia clinic. And they found that these intermediate cases, for approximately half of the cases, you would find a positive amyloid scan, and approximately half of them we would find a negative scan. So the intermediate cases are certainly not telling you is this a clearly positive or negative case. So again, PET might be helpful here to discriminate. What about therapy monitoring? Can we do this with the plasma or CSF biomarkers? In fact, there are changes induced by therapy, also in the fluid biomarkers, but they are not directly reflecting the changes in amyloid level. We see on the left side of this slide that on the drug, the plasma levels of the p-tau were declining during the therapy, but this decline that we see on the right side of this slide was not strongly correlating with the decline of amyloid levels in their brain with regard to the aggregated amyloid. And again, this makes sense, of course, because the fluid biomarkers measure the disease activity. They measure basically the process, the dynamic process of aggregation, and amyloid PET measures the aggregated stage of pathology. So it makes sense that these two are not reflecting the same thing. And again, as for staging, the same thing applies also for therapy monitoring. They are not interchangeable easily. Maybe in the future we will find ways that the biomarkers are indicating what is happening in one category with a biomarker of another category, but it's clearly not the same thing. So maybe for nuclear medicines physicians, it may be important to know these limitations of the fluid biomarkers, so I try to list them here to give them to you also for discussion with the referring physicians. So for all fluid biomarkers, we can say they have no regional information, say they don't give us any idea on where in the brain is pathology located, how much is located there. So there are issues with patient inclusion, with differential diagnosis, with staging, and with therapy control. Some of them have limited specificity. They don't reflect one particular pathology, but rather a mix, as some of them are even from the basis mixing, let's say, A-beta and tau. The CSF biomarkers, of course, have the issue of invasivity that patients also don't prefer this test, and they have this intermediate cases. The blood biomarkers still have the issue of not being fully validated in real-world populations, and they have the susceptibility to co-pathologies that we need to be aware of. So the summary here is that PET and fluid biomarkers are complementary and not interchangeable, and that PET measures extend on location of aggregated pathology, and the fluid biomarkers rather measure a dynamic soluble process. And we came up with this suggestion here how to combine them in a meaningful way for the future. And what we believe is that the plasma test should be a screening procedure which could be easily performed in patients, even in outpatient settings, and then leading to a pre-selection of patients who are suspected to suffer from Alzheimer's disease. And then we would perform a confirming test, which could be either PET or CSF assessment, with that limitation that we also in CSF have some inconclusive cases, as I demonstrated. And after that, we could then forward the patients to therapy. So I thank you, and we move forward to the next presentation of Professor Movelli. Thank you very much.
Good afternoon, everyone. We will now move more into the details of the appropriate clinical use of amyloid PET. And when we are discussing appropriate use criteria, we are first of all discussing these two very important papers. The first one published in 2013, the revised version published in at the early beginning of 2025. The first comment is that more than 10 years are quite a long time between the two papers, and very likely what was really important for the revision was not only the inclusion of the criteria for tau PET, but most of all the need for a accurate diagnosis in all cases, also to support the use of anti-amyloid drugs in the US and in other centers. Because if we compare the criteria from 2013 and the revised criteria published earlier this year, you can see that the focus this time is not only on early onset Alzheimer's disease, because we need an accurate diagnosis regardless of patient's age, especially if we want to treatment. The focus is not only on a typical presentation, but also on patients with a presentation which is consistent with the possibility of Alzheimer's disease, because we know that clinical diagnosis is not accurate enough. And clearly, as Alex said, the focus is always also on patients with unconclusive CSF results, because it is a main indication for amyloid PET. So I will very briefly discuss reading and interpretation, although I know that this is something that it's quite clear nowadays. So the three different fluorinated traces have been validated in the phase 3 trials with different color scales and different criteria that are, in any case, quite similar. A negative scan is characterized by preserved contrast between the aspecific binding and uptake in the white matter and the uptake in the gray matter. In general, it's important to remember that our visual analysis comes to a positive or negative dichotomic definition, but it starts at the regional level, so it's somehow different with respect to the process that we will see for sandyloids, a global score since the beginning. And we could always remember that, for example, floor beta peer criteria also include the occipital lobes, and flutemetamol criteria also include the striatum. So these are two peculiarities. But I don't believe you need more information on this, but you have to prove that I was right, skipping a further discussion of visual reading. So the first question for you is, how would you interpret this amyloid PET image? Negative, positive, or I'm not sure? You can answer now. it's just one slice. Not so fair for you. Okay, I was sure you knew your stuff about amyloid PET. That's why you are here. And very often, visual reading is quite straightforward. It's easier with respect to FDG PET. We might remember that there are some situations in which borderline cases might be due to some technical issue that we should always try to avoid. So low signal-to-noise ratio, important to keep in mind the correct doses and acquisition time. Off-target binding, even with amyloid PET, sometimes at a meningeal level. Movement, especially when they are in between the CT and the PET acquisition, and cortical atrophy. We know that this is an issue, that it might give us the false impression of a preserved contrast, while atrophy, which is actually also one of the features of the disease, might make more challenging the identification of a positive scan. But very often visual reading is quite easy, but the clinical case might be complex if the clinicians are asking for our help. So this is a case of a 75-year-old woman with MCI. The neurologist was asking, first of all, for CSF. And as you can read there, the results are, apart from the number, really borderline. Maybe total tau is positive, but not that much. Total tau is N for the ATN categorization. It's really borderline to possibly borderline negative. So in this case, the clinical presentation was for the clinician quite suggestive, so they decided to go for a second biomarker. Just a comment from my side, FTG could be considered, but nowadays, especially it's a case from 3 years ago, they wanted to include the patient in a clinical trial with anti-amyloid drugs, so they asked for an amyloid PET. And here is the amyloid PET, and again, I would like your opinion about these results. It's a floor beta peer scan, despite we don't see very well the cerebellum. Is absolutely positive. The quality of images is not the best, was in a clinical trial. Sometimes in clinical trial, you cannot use the optimized acquisition that you use for your patient. What was surprising for me is not that the scan is clearly positive. It's false into one of the cases that Alex describes us, but is markedly positive. It's impressive, this different. I don't have the time to go into the details. In this case, she was coming from North Africa, so maybe the cutoff locally defined was not the best for her, but I'm not even sure this was the reason. In any case, she entered the trial. I discussed with you visual analysis. Lidwin will go into the details of centiloids, but I want to link all the information that you will receive with the important to use centiloids also for us, from a nuclear medicine clinician, clinically oriented. You will see these numbers with Lidwin. Just I would like to comment that we have, let's say, an optical validated cutoff of 25, which was used also in clinical trials, and that we have a gray zone that are maybe at least between 20 and 30. But what I would like to discuss with you is the link between visual reading and centiloids. First of all, since the beginning, our impression was that A+, A- is not enough to capture the complexity of Alzheimer's disease. It's not enough to capture the huge number of information that we can obtain from amyloid PET. And in this case, in the second scan that you can see there, it's really a borderline case. And actually, centiloids are confirming. 20 is really falls into the middle of a gray zone. You might argue that centiloids were not of help, because my feeling was borderline and the result is borderline. But it is not true, because you put these results together with all the other clinical and biomarker information that you have from these patients. And in some cases, for example, long history of mild cognitive impairment and borderline scans is informative in any case. It can give you the idea of how to weight the impact of this brain amyloidosis and the final diagnosis. And then it's important, from my point of view, to add visual reading always, not only for quality control, but also because we can have two ways to read these images, and this human factor that we can add is of value when we are evaluating patients for diagnosis and for treatment, because when something goes wrong with the fluid biomarkers, you have this number. Maybe you can repeat the assay sometimes. This time you can also understand why the results are discordant. You have many reasons to discuss the images with the clinician. And again, just a small comment, Lidwin will comment more deeply this. It's very difficult for me to distinguish visually 50 from 90 centiloids. She will provide the reason for which it might be important in the future, and that's why centiloids will be important for us. I would like to strengthen this point by very briefly discussing with you this editorial from Professor Knopman for the Mayo Clinic, published in 2024, and I have to admit all these points were not so clear for me in 2024, but they were clear for him. First of all, the burden of brain amyloidosis that we can measure with centiloids on amyloid PET can help us to more clearly define the duration of this accumulation, and possibly again to link this value with the final diagnosis and will the weight of the different component of underlying patient's diagnosis and cognitive impairment. Just a small comment. For many years, we have seen this plateau on amyloid PET. Is true, it's very early, so the plateau is there, maybe when we see the patient. But it's not all a plateau if we look to it with semi-quantification. We can really obtain more from our images, and something which is really surprising also for me. I would never think to be a ENM Congress saying these kind of things. I'm not saying there's a correlation with the clinical presentation. FDG and tau PET do this kind of correlation, but we can obtain this information. FDG PET has also a role sometimes to disentangle copathology or differential diagnosis, but here I'm mentioning FDG PET to show that amyloid PET is also actually able to provide information about not only A, but also N. I think everyone knows now that given the lipophilicity of the tracer, the first 5 minutes gives us the idea of perfusion. The distribution is according perfusion. And then they can track N, and they can help us to obtain a similar information to the information that we can obtain from FDG PET. This is relevant for several reasons, historically for differential diagnosis, especially when the scans turn to be negative, but also maybe for copathology, to have a complete idea of the patient in front of us. And this is a position paper that you can find is open access in the first issue of the new ENM journal. So when we come to our communication, very important in this impressive moment for the history of Alzheimer's disease care, clearly the clinician will communicate with the patients and their family. We need to communicate with the clinician through the report, so we have to be very precise and accurate. This is what we do in our center. I think it's quite general. Clinical question, visual impression of the images according to the criteria. As much as you can, semi-quantification, possibly with centiloids, but there are situations, Lidwin will discuss these, in which Z-score might be very useful. The conclusion is, first of all, positive or negative with respect to brain amyloidosis. We will see later on in the future. And borderline, or I would say atypical positive case in terms of distribution might be mentioned. And again, you will see more deeply in the Lidwin presentation. So thanks to the peer review team, I received this model from the US. And it's very structured, very interesting for us as a European nuclear medicine physician. Just a couple of comments. Reason for amyloid PET, you see, basically therapy is the main. Diagnosis falls in the other. It was very surprise for me. And then there's a question, did you use semi-quantification, yes or no? Not very nice to say no, because the subsequent question would be why? Why not? For my point of view, we should try to take as much as we can from these images for the benefit of the patients and for the benefit of our field, because we really contributed a lot to reaching these important results in the field of Alzheimer's disease. So we need to be at the proper level. Fluid biomarkers provide 2 cutoff. We need to use all the information that we can derive. Very quickly, I will provide the other indications included in the appropriate use criteria. Clearly, eligibility. For sure, eligibility might be done also with other biomarkers. And I would like to show you a case that I reported 2 weeks ago. And this is a case of a patient that was sent to me for the evaluation for therapy. In Italy, we are not yet treating patients with in general, but compassionate use treatment will start soon, probably, so they are already screening patients. This is a 72-year-old man. The cognitive complaint started 5 years ago, so quite slowly. FATSECA score was 2, so not negligible. CSF was performed, and I would say A+, T+, N+, clearly evident. So amyloid PET was performed not for diagnostic purposes, but because the idea locally is to collect this data, first of all, to understand which kind of patient we are going to treat, especially now at the beginning in one center, such as a university hospital, such as mine. This is the result, and I would like your opinion on this real-world patient. It was that I recently saw. It's negative, don't even very difficult to report. It was a great surprise for me. Maybe it's, if I can come back to the slides, maybe in the occipital lobe, which is actually not part of the criteria for beta-ben, which was in this case, maybe a bit in the parietal, again on the right side, but it's clearly negative. It's 7 centiloids. Just to give you an idea of the report, we also have always a look to a Z-score, interesting, because it's providing a semi-quantification more similar to the process that we do when we look regionally to the images. Again, I don't have the time to go into the details. It's one of the cases, true real-life cases that Alex was mentioning. I can say that from the diagnostic point of view, you might say this is an Alzheimer's disease patient because it's ATN. Possibly in some cases, CSF is earlier positive than amyloid PET, but in the trial, this patient would have never been treated. So we are also, the presentation was a bit atypical, so we are also waiting for the results of a genetical test on C9orf because it's a complex case. The first one, it's always very complex, as you know. So finally, to conclude, monitoring response is very relevant. Everyone knows these two figures. We will need to familiarize with the treatment-related amyloid clearance, the definition of what we will see in our clinical practice. Alzheimer's Association has a working group and a publication starting with terminology. This terminology refers to a patient who previously had a confirmation of brain amyloidosis, then was treated, and then a clearance was demonstrated, which is currently possible only thanks to amyloid PET. It's not possible with other biomarkers, so we'll be highly involved in this. Also because, as you know, in one of the two trials, in the donanemab trials, there was a possibility to stop treatment based on predefined cutoff. There's also a demonstration that the accumulation after 1 year is not significant, and that the patients, if the patient reaches a value below 11, so similar to a young adult without brain amyloidosis, it takes around 4 years for the accumulation. So you might argue that not all the trial included the possibility to stop treatment thanks to amyloid PET, but still, as nuclear medicine physician, we know very well that thanks to PET, in general in oncology, for example, we can identify non-responders. This is true for donanemab, this is true for lecanemab and any other future treatment. Think about the use that we do of FDG PET in Hodgkin lymphoma. Interim PET is to identify non-responders, most of all. So I believe that it's a role regardless of the treatment. So how to support this evaluation? Visual and semi-quantification are both necessary according to indication that we receive, and I fully agree. So one question can be, is baseline amyloid PET necessary to then perform a patient's monitoring? As we know, it's not sometimes easy to find the spot on the scanner. I would say that from the methodological point of view, centiloids are a standalone measure, so it's not mandatory. But the emerging data on baseline amyloid PET makes me think that, especially now that we are starting this new activity, as much as we can obtain information on this kind of patient, as much as we can understand who we are treating, and later on in the future, if we can define very early who is going to respond, who is less likely to respond. Thank you for your attention. So Ludwin will now go on.
Good afternoon, everyone. This is going to be the talk with the most heavy number of polls, so please have your phones at the ready. And we want to go a bit more into what quantification can already bring us now, and maybe also potentially in the future. So, poll number 1. Which of these scans do you think is positive? Scan number 1, scan number 2, or both, or neither? Please put in your answer. So in this case, both scans are positive, and I can tell that here we have a very experienced crowd, which is of course very good. But I've shown these images to other less experienced crowds where very often only the right scan is being assessed as positive. And what I want to illustrate with these two cases is both are considered to be positive. Of course, the extent of pathology is very different between the two. And maybe the left one, where it's a bit more towards the borderline, quantification could support us in identifying these cases being positive as well at a wider scale, a less experienced audience particularly. And as we're moving to earlier diagnosis and maybe earlier intervention, this will be particularly important for the future. So the use of quantification in our clinical routine has sort of been established with these two, I would say, hallmark papers where many studies in the clinical population and many different softwares were tested, showing a very high agreement between the gold standard visual read and quantification. However, it is not a perfect world. Also, studies came out that there is extensive discordance between quantification and visual read. And as I mentioned, ever moving earlier in the disease, this might increase. There are many reasons for potential discordance, and I'm hoping to show a few of them to you today. But one of the limitations was also the lack of harmonization and standardization of the quantification approach. And for that, we came with the Centiloid scale. It was already mentioned, so a little bit more in detail on that. The use of Centiloid has increased dramatically over the past few years because it's become a standardized approach, but also used in trials as inclusion criteria and even as outcome measure. And here you can appreciate in this graph on the x-axis the change in Centiloid versus the change in cognitions on the y-axis. Because of the increasing use of Centiloid, it was needed to also provide with standardized guidelines on how to implement it in the clinical routine. So the Centiloid framework, what it provides us is this standardized measure where we scale our SUVRs to a common scale. So here, 0 Centiloid based on a cognitively unimpaired amyloid negative reference population, while 100 Centiloid represents the average uptake in dementia cases, dementia due to Alzheimer's disease. This means that this framework allows us to say 50 Centiloid in a site in Amsterdam means exactly the same as with a different tracer at a different site in a site in Cologne. And now we have a standardized measure that also is interpretable, and we can come up with guidelines how to use this in our clinical routine. Based on the literature, together with Ariane, we made an overview of the AMIPOD consortium on what is this scale of Centiloid and what does it represent. This figure is shown a few times already. In general, what we observed using different reference types of populations is that below 10 Centiloid, you can reliably exclude the presence of A-beta pathology, while above 30 Centiloid, you can reliably include or detect the presence of A-beta pathology. Based on the evidence that we provided to the EMA, this has also been approved to be used clinically in Europe. We also tested the value of these cutoffs with readers in the AMIPOD consortium, which was a large European consortium of clinical cases. From this consortium, we took 85 most challenging cases, either those around the borderline or that were assessed with a low confidence, and 5 readers assessed the different scans before and after disclosure of the Centiloid value. 2 of the readers are actually on this table at the moment. And what we saw post-disclosure of the quantification is that the readers considered in challenging cases Centiloid to be useful as 75% of the reads. There was an increase of reader confidence, and there was an improvement in reader agreement. You can see here in the kappa. But still, there was a few discordance between readers before and after disclosure of Centiloid, and I'll go through a few cases with you. Before we do that, because of the evidence has been grown over the past years of the value of quantification, and particularly Centiloid, these are now also available in some of the software. We have a few just examples to show you how it has been incorporated and available for the readers. Here we can provide quantification of the standard regions of interest, and often the standard reference region, the whole cerebellum, is used also in these different reader platforms. And here's an example also from NeuroQ for software, for example, that gives very nicely also regional abnormality images. All right, so going to the cases that we see, even though the concordance between visual read and quantification has improved, with all the standardization and harmonization has taken place over the past few years, some discordance remains. So how would you interpret this image? Will you say it's negative, positive, borderline, or I'm not sure? Please fill it in. All right. So this was a very tricky case. We had the 5 readers in our study. I can see the majority has assessed it as positive. That's very good. Within our study, 3 of 5 readers also assessed this scan as positive, but with a lower confidence. So we had a confidence on the Likert scale from 1 to 5. The confidence was 3. The quantification, though, suggested a really a higher Centiloid value of 42. And what's happening with this scan is that it's a bit lower quality and some movement has taken place. After disclosure of the Centiloids, all readers were now comfortable with calling this scan positive, and also the confidence of the readers increased to 4.2 on the 5-point Likert scale. A different case. How would you interpret this scan? Negative, positive, borderline, or I'm not sure? Give this some time. All right. So I see the majority here has assessed this scan as positive. Interesting. The readers in our study actually called this scan negative, albeit with a low confidence. And it's mainly because what we're seeing here is an atypical uptake, mainly in the posterior part of the brain or a bit in the occipital lobe. Because the occipital lobe is not part of the centroid mask, also the central quantification fell very low. So it suggested a negative scan. And because of the guidelines of what we can call, of course, an amyloid positive scan, the readers state we're saying this is a negative scan because occipital amyloid pathology is not captured. Please keep this in mind. I'll come back to it in a second for this particular atypical pattern. The final case I wanted to present to you, how would you interpret this image? Positive, negative, borderline? I'm not sure. So here, everyone, again, the majority is calling it a positive scan. Also, our readers call this a positive scan. What's interesting is that this is a similar situation that is a bit of an atypical pattern, mostly in the back of the brain. But now, in addition to occipital burden, there's also temporal burden. And based on temporal abnormality, you're allowed to call the scan positive. Nonetheless, the centroid is still extremely low for this case, because also this very posterior sort of basal temporal region is not captured properly in the centroid mask. But our readers stuck to their guns and kept calling the scan positive, even though the centroid quantification was indicative of negative. Here, the Z scoring actually helped and supported a positive read. So just to summarize this part, what's important, and already alluded to by the previous speaker, is that quantification should be used always in conjunction with visual read. And in cases of discordance, you can be aware of quality of the image, potential lesions that can affect quantification, but also focal uptake that might not make the quantification elevated enough, even though visually it's clear there's abnormality. But of course, also the other way around. Focally, visually, you might not certain a scan is positive, but the quantification is support you to actually call it positive. So, a little quiz question for you guys. Which causes could that be for discordance between visual read and quantification? Quantification is wrong due to incorrect placement of the target or reference region. There's not enough focal uptake to increase the centroid metric sufficiently. There's focal uptake that is not captured well with the centroid mask. The reader missed a region while there is focal uptake. All of the above. All right. Yes. So the answer is, there's a lot of reasons we can have discordance between quantification and visual read. Hence the importance to always perform both and be certain, have as much information as possible to make your final assessment. All right, what are the next steps for quantification? Because in general, we now have a very good standardized, harmonized approach with values that mean the same thing between different sites and different readers that can help us with our assessment of a PET scan. But what is the next step? I showed some examples of atypical uptake. And I saw already some examples, also Sylvia as well, on that the scale of quantification, of course, goes beyond amyloid negative and amyloid positive. We have this whole range of the centroid scale that we're basically ignoring at the moment. There's been studies, although limited. I think there's more work needs to be done, but this alludes to the potential of using more of the scale beyond the positive threshold, showing that at 50 centroids, there's an increased risk of becoming tau PET positive. Similar studies have shown at around 36 to go to medial temporal, lateral temporal tau, and in the donanemab trials, they showed that the cutoff between intermediate and high tau is at 60 centroids. So that means that within the positive range, around the 50 centiloid cut point could be a risk indication for being actually cortical tau positive, which could help further with the staging approaches of our quantification. The other point was the spatial patterns. Work by myself a few years ago, I looked into 3,000 different scans from 6 different cohorts and applied the subtype and stage inference model, or SUSTAIN. Maybe you've heard of it also from the tau-PET subtypes. While tau-PET subtypes are more accepted and more also seen to be correlated with cognitive profiles, I also found evidence for actually amyloid PET subtypes, a frontal, parietal, and an occipital subtype. These subtypes have been validated within my own group with different data set and a different approach, but I also saw at AAC last summer that was presented by the group from the IDEA study, again a different data set and different approach, and they also found a very strong occipital subtype. So what could this be of interest? What we found so far is that a frontal subtype seems to be associated more often with APOE4 carriership and a more classic AD profile. The parietal subtype was more common in early onset AD, and the occipital subtype particularly has gained a lot of interest in the past few months because it has been associated more often with dementia, faster cognitive decline, but also particularly vascular pathology. We previously saw that if you had a posterior amyloid pathology pattern, you also had the tendency to have more vascular pathology in the backside of the brain. And recently at ASC, Lilly presented on occipital burden and the incidence of ARIA in their trial data. Very interestingly, those that had elevated occipital uptake compared to the rest of the brain were at higher chance of developing ARIA-E. And even within the carriers, there was an added effect of occipital uptake on top of being an E4 carrier. So I think that really shows that also the spatial distribution of amyloid PET could actually support some of the risk stratification within our clinical routine. And so a question to you, based on the evidence I've shown so far, is do you think regional amyloid PET could be useful for quantifying the extent of pathology, risk stratification, differential diagnosis, identifying primary etiology? I would say there's mainly evidence for risk stratification, that the patterns can help us with giving an indication for side effects and maybe also for the extent of pathology that could be used for staging. But who knows what the future holds for the other points. And with that, I thank you very much for your attention, and I'll give the floor back to Alex.
Thanks very much. The mic working? Yes. So for the last part of the session, we will now give a little bit a glimpse into the future and discuss a little bit also on the promise of tau-PET, which may be helpful for future application. We saw some data on this already before. So there are different tau tracers available. In general, the one approved in the FDA and also by the EMA now is the AV1451. And you see typical images here on the left side of a healthy control with rather little cortical uptake and some subcortical non-specific uptake. And on the right side, we see a patient with Alzheimer's disease with this intense uptake reflecting an advanced Bragg stage of tau pathology here in the brain. And that has also been now tested by in vivo versus post-mortem correlation that this tracer uptake, in fact, reflects aggregated tau pathology in the brain. And as mentioned, this is also approved in Europe for application, unfortunately not yet commercially available. So what are the advantages of tau imaging, also as maybe compared to amyloid imaging? The tau tracer seems to be more specific with regard to the location of neurodegenerative pathology. And we see on the left side, we just discussed the distribution patterns of amyloid, but we see here on the left side that for tau it may be even more clear on where in the brain actually neuropathology is ongoing. And you see different subtypes of Alzheimer's disease here. A typical Alzheimer's disease, a more frontal behavioral type, We see the so-called posterior cortical atrophy, patients who do have strong occipital uptake of the tracer, as you may also appreciate on this image. And we have this subtype of the logopenic variant, progressive aphasia, patients who do have language issues and often have unilateral temporoparietal aggregation of tau. So all of them would be usually generally positive in the amyloid scan, but you could see more clearly where in the brain disease is ongoing, and that might be, of course, also important for disease stratification for the future, as you can believe that these patients certainly will not have the same course over time as their pathology is located differently in the brain. It has also been demonstrated that even on the basis of the tau pattern, you could discriminate between amyloid positive and negative subjects, and that is also why tau PET is now also discussed as a potential inclusion criteria for including patients into anti-amyloid therapies. It needs to be said, however, that this is only below a certain level of amyloid, because there may be amyloid-positive patients that still do not have tau in their brain. So it doesn't work this way around, but it works the way around if we have strong tau uptake, that we can discriminate amyloid positives and negatives. And also there are second-generation tracers that might allow us to detect also the non-AD tauopathies, such as in PSP or corticobasal degeneration. It has been demonstrated that tau PET has also a value in early diagnosis, as I mentioned, not many years before onset of disease, but nevertheless it can predict conversion of MCI to dementia. That has been demonstrated. And it may also predict conversion of cognitively healthy subjects to mild cognitive impairment. However, that is the case only in amyloid-positive subjects. So if you have an amyloid positivity and a positive tau scan in a cognitively healthy subject, this subject has a very high probability of about 50% to convert to cognitive decline within 3 to 5 years. So it's not decades ahead, as it may be the case for amyloid, but it is possible in combination of the two to predict even decline in cognitive healthy subjects. It has also been demonstrated that a level of tau may be predictive with regard to the response of anti-amyloid therapies, and this is demonstrated here for one of the drugs, where this has been shown that the low tau group had a better response of the therapy as compared to the entire population, including higher tau subjects. And there's also more recent data demonstrating that some subjects being on anti-amyloid therapies, even 4 years after starting the therapy, may be still at the same level or even slightly improving if at the baseline they were at the very low tau levels. So it seems to be predicting about the value of the therapy in the future. Also, tau PET is very helpful for staging. That has been demonstrated in several trials. The uptake in the brain, in fact, reflects the neuropathological stages of disease. And again, this is something that could, of course, be very difficult to do with a fluid biomarker, as we do see the intensity of uptake, we see the extent, the distribution of the pathology. So there's a lot of additional information that we need to be aware of as compared to the fluid biomarkers. These are the recently introduced revised appropriate use criteria that now also include the tau PET. I will not read now all of them, you can look them up. Importantly, it is supposed to be appropriate now in situations or indications that used to be called appropriate for amyloid imaging, funny enough. So this is MCI or dementia with early onset. It is possible AD with atypical features. It is to inform on prognosis of patients with MCI, and as I mentioned, also to determine eligibility for treatment with amyloid-targeted therapies. It's quite interesting that in typical forms of dementia, it is not yet suggested to be appropriate, but still uncertain. That is as it used to be in the past for amyloid imaging, so maybe we will move there in the future as well. And also it is still considered uncertain to stage or track disease progression, which is a bit puzzling, in fact, because this is exactly the T2 core indication for tau imaging, where it is suggested to be useful for staging of disease, and we think this is also the case. So maybe that needs to be debated in the future then as well. It can be assessed visually, as we can see on the left side of this slide. This is the way it should be read at the moment according to the package insert. There are several indicators on where we should look in the brain, particularly we should not be looking at the mesiotemporal lobes, but rather the lateral and posterior part of the temporal lobes, and then classify a scan in either positive or negative, so still a categorical judgment, but there's a lot of work currently ongoing to also move towards a quantitative assessment, similar to what we learned just in the last presentations about the centiloid assessment. And I'm giving just one example here on the so-called Centaur scale, which is also trying to bring different tracers to a standardized way of interpretation, and also to a quantitative way of interpretation, which would be nice if we had like an amyloid value standardized and also a tau value standardized available. So I think we fortunately have a little bit time left still also to look at a case here undergoing a tau PET scan, and this is an example of a patient who was 72 years old and demonstrated at a dementia unit with difficulties mainly in reading, with orientation problems, recent issues with driving the car and using tools. The neuropsychological tests demonstrated also visual impairment, but only relatively minor impairment in memory, so there was a discussion, is this an Alzheimer's disease or not, or what else? And first an FDG PET has been performed to also discuss a little bit the value of FDG PET here. We see these results here with the posterior hypometabolism, as we can see on the left side, and also on the comparison with controls. And then a tau PET scan has been performed. And you see the tau PET scan here in the bottom row of the image. And I think it's quite nice to see here that it is more or less upside down or inverse to what we see on the FDG PET. So we have an uptake here in the posterior parietal cortex and also extending into the visual cortex at this location. So we would now ask the question about this patient based on the symptoms, the FDG and tau PET results. Which of the following would you conclude? First, the patient probably has a positive amyloid scan. Second, the patient needs to see an ophthalmologist. 3, the patient probably has an abnormal dopamine transporter status. 4, the patient may have an encephalitis. Or 5, the patient, not the patient, you are not sure about what the patient has. So then please decide on these choices. I was going to ask for the music. Oh, I'm not seeing the results here, but there, okay. So the patient probably has a positive amyloid scan. Is this moving forward? Yes. So most of you picked the right answer. This is a patient with a typical atypical form of Alzheimer's disease. So this is posterior cortical atrophy, which is a variant of Alzheimer's disease, which is not all that rare. And we learned in the recent years that the so-called atypical forms of Alzheimer's disease are relatively frequent. And these patients, in fact, often go to see an ophthalmologist. And there's a lot of discussion then why their vision is impairing, because they are not apparently in demonstrating the memory problems in the first line. They develop this later on, unfortunately. The amyloid PET, as we can see here on the right side of the slide, is clearly positive in that case. We see this posterior parietal hypometabolism in the FDG PET. And in tau PET, the similar pattern of increased tracer retention. And I'm showing this here because it quite nicely also demonstrates the complementary value of the tau and the amyloid scan. If you look at both of those, they are very, very different. We can see amyloid distributed broadly across the brain, and tau only in the areas also affected by dysfunction in this patient. So we are basically already at the end of our session, and there are, I think, a few take-home messages that we try to convey here. First is that the advent of disease-modifying therapies for Alzheimer's disease is changing the landscape for neuroimaging for AD. The most important message here at the Nuclear Medicine Conference is certainly that amyloid PET is to be considered the current gold standard for identifying patients for anti-amyloid therapies. In the near future, it may be used also to decide when to stop the therapy, or maybe also when to again reapply the therapies. There's of course first data just now collected as the therapies are still very new. If it is making sense to continue them for a long time or even to restart them if a certain level of amyloid in the brain is again reached, it would make sense. And I find it very hard to see how we would judge this on the basis of fluid biomarker tests. The tau PET may be used for patient selection, is already even appropriate. Unfortunately not yet available in Europe. We are hoping that it will become available also in the future. And we saw that the tau PET may be sort of a universal tool as it answers many questions at once. We learned, I think, in the nice presentations that quantification can clearly support the visual assessment. And the Centiloid provides a standardized measure or cutoff for therapy inclusion. And I can only mention that when we started to put this in our reports, then suddenly the referring physicians were also always asking for that value. So they are very quickly getting adapted to this nice concept of having a number with regard to the level of pathology. We also saw that tau burden with regard to quantification may also predict therapy response of anti-amyloid therapies. And we try to transport that patterns matter, that the regional assessment is important, that even on amyloid PET we can see subtypes and potentially predict the risk for anti-amyloid therapy side effects, which are these so-called ARIA in the brain, which is of course of huge importance as they may be also critical. It would be nice to know this in advance if a patient has a higher risk here or not. And that the tau PET regional patterns may also be helpful to discriminate Alzheimer's disease subtypes, but also potentially different types of tauopathies in general. So we are done with this, and now would be all of us open for questions, and we would ask you to come forward and ask us whatever you are still interested in. Thank you very much for your attention.
All right, we'll start with online. Alex, one for you. Would you include ApoE4 results in algorithms, plasma algorithms, to lead patients to amyloid PET or CSF? If yes, how, where, when, and how?
Too many questions. So
yes.
How did it start? Would I put it in algorithms?
The ApoE4, I think, in the screening
yes.
algorithm. Yeah.
Yes, that's a very good question. And I just talked to a colleague yesterday. We did a study many years ago where we sort of boxed patients with a positive ApoE4 status and an abnormal FDG scan into one corner, and patients with an inobvious ApoE, so without an ApoE4 level, and a normal FDG scan in the next corner, in the group of MCI patients. And they had, one of them had the 100% conversion to dementia, the other group, being negative in both tests, was 100% stable. But of course you have in between a gray zone that is very big, and as compared to what you showed for the centiloids, there's a gray zone that is quite small, but for this kind of test it was very big. So it is certainly there's value in ApoE screening, and we need to do it now also for therapy inclusion. So basically we will have these results available. I'm not yet sure we should basically stratify patients in general, and I'm also a bit worried that we are currently excluding patients who are ApoE positive because we know they suffer from this disease more quickly. And it is a bit paradox that particularly in these patients who have a very aggressive amyloid aggregation, we would not want to treat them. But of course at the moment there's the worry that the side effects in these patients are quite dominant, and the effects are not as huge that you would go into this risk. But that being said, if I was an ApoE4 positive, I would probably want to have the treatment. So we will have to see in the future if the risk can be mitigated in some way. Yeah.
Maybe if these results about the regional, the occipital burden confirmed to be relevant, clearly we might go beyond, also regulatory authorities might go beyond the ApoE.
Yeah.
Maybe to jump in on that one with another question we got online is whether occipital should be included into the centiloid mask. I would actually say no. For two reasons. One, Centroid is now quite validated and standardized, so it's something we can use to give an indication on the extent of pathology. And also, the presence of occipital amyloid is present in a subset of patients. And it seems to be almost maybe an independent risk factor by itself. So it's probably something that we need to take into account in the future, and more studies will go to it. But I don't think at this point we need to include it in the centroid mass because it has its merits on itself. But we need to see what is the risk by having occipital in addition, or maybe primarily, because isolated occipital is quite rare. The case that I showed is really a rare example of having this posterior pattern. But you do see individuals that have extensive amyloid pathology and occipital, but also those with extensive pathology without occipital. So taking that into a standardized mask, while it's such a heterogeneous region, might, decrease the value of the centroid mask from that perspective. Then a question for Sylvia. Where was it? I had it here. Oh, yeah. How should clinicians interpret amyloid PET in the context of discordant clinical findings? So dementia without amyloid or amyloid without symptoms?
Amyloid without symptoms is not a part of the clinical routine, so at the moment we don't see this kind of patient. Symptoms without a positive amyloid PET might suggest a different underlying etiology, a surprise it comes. That's why early perfusion imaging can guide, otherwise CSF is not yet performed, can be informative in inconclusive cases. And sometimes also borderline results might testify that the main underlying etiology is something different, so that there's a relevant role of copathology, which can be vascular, TDP-43 or others that we will familiarize more and more because they are relevant to understand who is, which kind of patient is in front of us and what we can expect or not expect from a therapy, for example.
And then mainly for a final question before closing off is, do you think that the baseline central measure could add more value than CSF test, and particularly for example, predicting time to clearance or the side effect of ARIA, so having the quantification from that perspective?
The baseline amyloid levels or the baseline,
the quantification?
Amyloid levels. Yes, there is also data on that already, that these levels are in fact also predicting on the therapy response, so I think it's valuable to quantify. And I think Sylvia also had on her slides that it's mandatory to do quantification.
At least strongly suggested.
Yes. So I would also say this is absolutely valuable, and we need to learn. I mean, this is all now just from clinical trials, but we will have to see from routine application on what value this quantification has. So I think it's really helpful, and I would also again motivate everyone to get if you do amyloid imaging, to get the centiloid established as well.
Yeah. We learn together.
So I think we are exactly in time, and we thank you for joining us in this session today. So thanks again to this very excellent speakers, nice presentations, for your participation and contribution. And you can also scan this QR code now for rating and downloading slides. And thank you very much for attending.